Good afternoon, all. Today we learn about folic acid synthesis inhibitors. So, before we learn about folic acid synthesis inhibitors, tell me what is folic acid? Folic acid, iron supplement. Then,
It's required for RBC production.
then, what is that basically? Iron supplement, okay? Yeah, vitamin. Yeah, what is the needed of vitamin in our body?
Chemical reaction,
Chemical reaction, metabolism, synthesis of purines, pyrimidines, then development of DNA. Okay, so basic is folic acid is involved in the synthesis of purines, pyrimidines and all. So now you will tell about the folic acid synthesis in bacteria. I will give the clue, you should tell, okay? First start with pteridine. Pteridine plus PABA. What is PABA? In turn, combination it will give dihydrofolate, diopteric acid. Then it will convert into tetrahydroteric acid, and then FH, that is tetrahydrofolic acid. This is tetrahydrofolic acid. FH is an active form of folic acid. This is an active form of folic acid. Okay, so this in turn will form undergoes in synthesis of thymidine, purines, and then proteins. Okay, for synthesis of DNA we need all this, no? That's why folic acid is very important. Now, folic acids are enzymes are necessary. Folic acid enzymes, not folic acid, enzymes are necessary for the synthesis of amino acids. So, hence necessary for bacterial protein synthesis. So, what we need to convert, so from pteridine and PABA to get converted into folic acid, we need enzymes. So, there are two enzymes very importantly. First, dihydro synthase, and here tetrahydro dehydroreductase. These are the two enzymes which is necessary to synthesize folic acid. So, our folic acid synthesis inhibitors will act on these two enzymes and inhibit the synthesis of folic acid. Okay. What are those drugs? We'll discuss about those drugs here. Sulfonamides. It has class. Sulfonamides and diaminopyrimidines. These are the two class under which it comes sulfonamides and trimethoprim. Okay. In sulfonamides, we have classification according to absorption in the GIT. So, first class, rapidly absorbed in GIT. One, like examples in rapidly absorbed in GIT, we have sulfazoxazole. Then, tell sulfamethoxazole, sulfazoxazole, sulfamethoxazole, sulfadiazine. And then poorly absorbed is sulfasalazine. And we have topical agents, topically used in for powder form. Sulfacetamide, Silver sulfadiazine. These are the drugs coming under sulfonamides. And in dipyrimidines, only trimethoprim. And combination will give cotrimoxazole. Okay. Now we'll see one class, one drug. Okay. So these drugs are susceptible to both gram-positive and gram-negative bacteria. That includes all Streptococcus from gram-positive, like Klebsiella, E. coli in the gram-negative. And then absorption and distribution. These drugs are orally absorbed well, and then rapidly absorbed also in GIT. And the major site of absorption is small intestine, and it's distributed throughout all the tissues. And these drugs reaches also CSF and placenta. So these drugs will be avoided in pregnancy. And sulfadiazine, one drug, that is sulfadiazine, which distribute throughout the body water. And so sulfazoxazole is confined only to intracellular spaces. These two drugs which is confirmed, like the distribution is through body water, so that is sulfadiazine, and sulfazoxazole is intracellular spaces. These two drugs will distributed there, like except those sulfonamides. And metabolism, main metabolism in the liver, and elimination is through urine and feces, and eliminated from the body partly as an unchanged drug. So what is is the drug required renal dose adjustment or not? No, right? Unchanged drug, it will go unchanged.
In liver or kidney?
Elimination, it goes unchanged as a drug. It don't change. Like urine and feces. Required or not? Yes. Okay.
Liver does it require, no?
It is metabolized in the liver. It should require. But it undergo unchanged as in urine. Yeah. Renal. Okay. We'll study about sulfazoxazole. Okay. This absorption is rapidly or poorly? Rapid. I written there. Rapidly.
No question. If it is excrete and changed, so does it require any liver bacterial exam metabolism? No. So does it require any assessment in liver problem disease? No.
It's metabolized in the liver.
Excrete and changed means
In urine, right? It's excreted.
So it will not convert to metabolites.
No.
It's okay.
I didn't get that. Okay, it has 95% of sulfazoxazole is excreted by the kidney, and a single dose in 24 hours. It is being given 24 hours, like single dose for 24 hours per day one, and it is highly solubly in the urine. Okay, and then and dose we have 200 to 400 mg, and half-life is 1 to 1.5 hours. And so this drug required renal and hepatic dose adjustment. And coming to second drugs, that is sulfamethoxazole, dose is 400 to 800 mg. What is the dose of sulfazoxazole? Now sulfamethoxazole 400 to 800 mg, and T half life is 11 hours. It has more half-life. And then slower rates of enteric absorption and urinary excretion are slower for this drug. And combination markedly only in the fixed dose combination. This drug will be only given with the combination sulfamethoxazole with. And coming to next drug, that is sulfadiazine. Dose is 200 to 400 mg, and T half life is 10 hours, and absorbed rapidly from the GI tract, and risk of crystal urea, that is 15 to 40% of this drug which is excreted in the acetylated form. So most of these drugs, sulfonamides, it will get converted into acetylated form and excreted as that. Excreted as acetylated form, and it causes crystal urea. So the patients who are taking sulfonamides, what is your patient education? Drink lots of more water, like water. You should drink more water. And fourth drug, the sulfadoxine. The dose is 500 mg and it can be given BD, TID or quarter to 4 hours, and T of life is 7 to 9 days. 9 days, and combination with pyrimethamine. Pyrimethamine. Yeah, what is the pyrimethamine indication? Pyrimethamine indication. Infection, we know. Pyrimethamine indication. Malarial, correct. Yeah, sulfadoxine, 500 mg sulfadoxine and pyrimethamine, it is used in the malaria caused by mefloquine and mefloquine resistant strains of Plasmodium falciparum. Okay. Adverse drug reactions of all these drugs, fatal reactions including Stevens-Johnson syndrome in the pediatrics, and resistance, most commonly resistance and hypersensitivity reactions. The therapeutic uses are UTI, nocardiosis. What is nocardiosis? Simply, I can't. It's an infection. Yeah. Yeah, nocardia. But what I'm asking about nocardiosis? Infection. What's infection? This is an infection most occurring in the lungs and sometimes whole body. Yeah. What is the main adverse drug reaction of this drug? Like sulfonamide, crystalluria. So drug interactions. So these drugs should not be given with anticoagulants and sulfonylurea hypoglycemic agents. Okay. So now we'll come to study about the combination drug. What is that? Cotrimoxazole. So cotrimoxazole, the dose starts from 80 mg or like cotrimoxazole is 400 mg and trimethoprim is 80 mg. What is the ratio? 1:5. 1:5. And mammalian cells. Oh, sorry, I asked. Yeah, this even mammalian cells or human beings will have folic acid. Even we have enzymes and all, but these inhibitors will not act on this folic acid.
Inhibitors are different.
Why? Tell me. Even we have folic acid synthesis.
Different enzymes.
See, in human beings will not synthesize folic acid. We'll take from agent like other. Okay, will not synthesize folic acid. So, cotrimoxazole, the spectrum of action will be both gram positive and gram negative. So, absorption is same like what we have studied about sulfonamides, rapidly absorbed, distributed throughout the body, all those things. And coming to like trimethoprim T of life is 11 and 10 hours respectively. Like trimethoprim is 11 hours, sulfamethoxazole is 10 hours. Only 1 hour difference. And distribution, trimethoprim will distributed and concentrated rapidly in the tissue and 40% of plasma protein binding, whereas sulfamethoxazole is only 65% of plasma protein binding. So, and volume of distribution, trimethoprim is almost 9 times than sulfamethoxazole. It distributes more than sulfamethoxazole. And elimination is about 60% of administered trimethoprim, and from 25% to 50% of administered sulfamethoxazole are excreted in urine in 24 hours. Trimethoprim is excreted more than sulfamethoxazole. Therapeutic uses same, UTI, respiratory tract infections and GI infections. Adverse drug reactions, same, crystalluria, but in combination we'll get anemia also, Stevens-Johnson syndrome, and permanent renal failure may occur, and then dermatological reactions are like rashes and all, and hyperkalemia. Hyperkalemia also is observed. Okay, thank you.